Dear colleagues and guests, good afternoon. I'm very proud to introduce Dr. Praveen Sharma. Dr. Sharma is a full-time NIHR doctoral research fellow and clinical lecturer in restorative dentistry at Birmingham School of Dentistry. Dr. Praveen provides teaching to undergraduate dental, nursing, hygiene, and therapy students in periodontology. His current research interests include investigating the impact of periodontal disease on general health of patients with chronic kidney disease. I welcome Dr. Praveen Sharma for the next CPD session.
That wasn't going to work. Thank you, Biju, for the introduction. Thank you for the organizing committee, especially Rosh and Priya, for the invitation. It's an honor to speak in front of so many people who you don't need to see a room full of often when you're presenting. I echo Monica's thoughts that the organization itself is really important, and I'm glad to be a part of it. And it is a huge honor to be here. I'm just going to load my presentation up really quickly. There we go, brilliant. Excellent. So as Biju said, my name's Praveen. I'm a clinical lecturer in restorative dentistry, and I'd like to talk to you today about risks in periodontitis. Okay? We'll talk briefly about where the risks lie when it comes to periodontitis. So there are risks involved in the disease itself, and we'll talk about risk factors involved in periodontitis. We'll talk about the risks involved in not diagnosing or misdiagnosing periodontal disease, and I'll talk about the risks to the patients of either treating the disease or not treating the disease. And this comes into play when we talk about informed consent later on in the presentation. Okay. So just by way of background, a risk factor is something that makes the disease progress a lot quicker. So there are two different things. There's an initiating factor, that's a causative thing. So that's a factor that you need to have the disease. And then you have risk factors. And risk factors are factors in the presence of which the disease is worse. So for periodontitis, the initiating factors are really simple. You need bacteria and you need a host response. And all of us have bacteria, all of our patients have bacteria, and all of our patients, apart from the ones in the ground, have an immune response. So pretty much everyone has the initiating factors for periodontitis. Well, what we can influence are the risk factors. And there's different ways of classifying these risk factors. So you can have localized or systemic. You can have patient or operator-based. You can have developmental or acquired. So there's different ways of classifying, but ultimately what we want to know is whether these risk factors are modifiable or not modifiable. Can you or the patient do something about these risk factors, or is this something that you can't help the patient with? And we'll see in our talk that these risk factors don't always neatly fall into these categories. Okay. So when we think about risk factors for periodontitis, it's again just useful to think about periodontal disease from basic principles. So periodontal disease is the interaction between bacteria and host. So your risk factors must do one of two things. It must either alter the bacteria in some way, either make them more abundant or make them more pathogenic, or alter the host response in some way. Okay? And all of our risk factors fall into these categories. And probing depth is a big risk factor, and we know that the odds of tooth loss when we compare a tooth with a 3 millimeter pocket are 8 times greater for a 5 millimeter pocket, 11 times more greater for a 6 millimeter pocket, and 64 times greater for a 7 or larger pocket. That doesn't mean that a tooth with a 7 millimeter or larger pocket is hopeless. Okay? It just means that pocket, if it persists at 7 millimeters, the tooth is much more likely to be lost. Therefore, the tooth needs treating. Okay? And again, the reason why probing depth is a risk factor is because you can imagine a deeper pocket has more anaerobic environment at the base of it, which propagates the replication of anaerobic bacteria, changes the microbiome within the pocket, makes it more virulent. Okay? So that's why it acts as a risk factor. The other risk factor important risk factor is bleeding on probing. And this is persistent bleeding on probing. And again, persistent bleeding on probing then provides the oral microbiome, the microbiome in the pocket, with a constant source of heme protein. And P. gingivalis as a bacteria loves to feed on heme protein. So you can see how the presence of persistent bleeding changes the bacteria types in the pocket and makes it worse. Okay? And again, we need to be careful when we're thinking of smokers because they may not bleed as readily. Smoking itself is a risk factor for periodontitis, and we know this. And smokers are more likely to get periodontitis. They're less likely to respond to treatment. When they do respond to treatment, the treatment is more likely to recur, and they're much more likely to lose teeth. And I'll just show this dose-dependent relationship between smoking and tooth loss. Okay. So the x-axis here is the amount of cigarettes that someone smokes. The y-axis here is the risk of losing teeth, and 1 is the risk of someone who's never smoked. Okay? So we can see that our average sort of pack-a-day smoker has a risk of, sorry, this doesn't project as well, has a risk of tooth loss that's 2 to 3 times that of a never smoker. So if your patient comes to you and says, well, I used to smoke 20 a day, I now smoke 10 a day, that doesn't mean that they don't have a risk anymore. That just means that they have a low risk. Now they have a 2.5 times the risk. If they go down to 1, they still have roughly a 50% increased chance of tooth loss. So when patients come to us and say they're quitting smoking, they've dropped down, that's really good news. Okay? But you just need to educate the patients and say, that's really good news, but you've got a little bit more to go still, so keep at it. You know, you're heading in the right direction. Diabetes is a big risk factor for periodontitis. We know that diabetics have greater attachment loss, greater bone loss, and clinically, when we see patients who have recurrent multiple lateral periodontal abscesses, that should trigger alarm bells in our minds. This may be a patient who is either a poorly managed diabetic, or more likely they're undiagnosed diabetic. And this is one of the few instances where we can really help the systemic health of our patients by diagnosing these things earlier. And if you've got a finger prick test in the office, then you can just do a quick blood glucose test and refer them on to their GP. The link between diabetes and periodontitis is so well established and so well acknowledged that it formed the crux of this year's Gum Health Awareness campaign. These PDFs are available via the British Society of Periodontology. If you'd like some copies, you'll have my email address at the end. They're for dentists, they're for medical practitioners, they're for your patients in the waiting room. So feel free to either reach out to the BSP or to myself for the copies of these. And then there are a whole host of risk factors. So we can have calculus buildup, we can have aging, we can have malpositioned teeth, we can have stress or genetic factors. And you can see that all of these only work in one of 2 ways. All of these either change the bacteria type or numbers, or change the host response or influence the host response in some way. And that's how they make periodontal disease worse. So it's really important that we identify these risk factors, make a record of them in our notes, and inform our patients to see if these are modifiable and if they can modify them. And that's what we'll move on to next, is the risk of missing periodontitis. So dentists, these are just some stats from risk-wise. Dentists get sued 2 to 3 times more than GPs. More and more cases are unrelated to what we do in practice. So it's not the clinical dentistry. It often ends up being the note-keeping or some other aspect that isn't directly related to clinical dentistry that forms the crux of these cases. And it's not just dentists that go in front of the GDC anymore. It's all kinds of dental care professionals. It's hygienists, it's nurses. And again, some of you may have seen these scary statistics before. From 2015, the top 20 claims, nearly half of them had some sort of periodontal component to them, and 2/3 had either a periodontal or an implant component to them. Okay. The cost of the damages for the largest case, which happened to be an implant case, were £750,000. And the key factors of these are the missed history of periodontal disease, smoking and patients not being made aware that smoking was a risk factor for periodontal disease, insufficient time and care in planning, and poor informed consent. And this is where we'll move on to next. Sorry, I'll just go through quickly. Particularly with periodontal disease, these claims tend to span decades, and they really form a gold mine for lawyers. They'll want to know, something about Mrs. X, and they'll request the notes, and 5 years ago you didn't do this, that, or the other, and that then forms the crux of the case. Patients can claim that they were never told, and if it's not documented in your records, then that's really difficult to show otherwise. So clear documentation is vital, and this includes the documentation of risk factors. And that's where risk assessments comes into place. It doesn't. So I'll present to you the Depo risk assessment software. This, I don't have a vested interest in the company. This is just a system that I'm familiar with. You don't need to have a bespoke system that does this. You just need to have a system that does it. It doesn't need to be like a software that does it for you. As long as you have a system of, okay, I'm going to ask my patient about risk factors A, B, C. I'm going to record risk factors A, B, C, and I'm going to make sure that my patient knows what the consequences are of managing these risk factors or not managing those risk factors. Okay. So the Depo itself is an online risk and health assessment tool. It gives good biofeedback to the patients because they sit in the waiting room with an iPad, fill these bits in. They answer some questions about their own health. So are you experiencing any pain? Do your teeth allow you to eat an unrestricted diet? And do you feel embarrassed about the appearance of your teeth? These kinds of questions. The dentist then enters some clinical data based on the BPE, so probing depth and bleeding on probing in sextants. Radiographic data if that's available on bone levels, and this allows us to create a bespoke periodontal risk and disease score for each of our patients. And then we'll move on to the risks of treatment or not. And this, I'll be presenting some research that hasn't been published yet. We're in the process of doing this manuscript, but this data comes from the Depo database. So this is data from around 300 dentists all around the UK, over 10,000 patients, so it's really robust data. Oh, here we go. 14,000, patients, 355 dentists, 233 dental practices, all around the UK. These are Dentplan practices. And here we can see that there's a nice spread of disease. So we have some patients who are healthy, some with gingivitis, some with history of or current experience of periodontitis, and some with a history of or current experience of severe periodontitis, okay? I'd just like to go through the results really quickly because it sort of brings home a few points. The x-axis here will stay the same for the next few slides, and these are a continuum of periodontal disease diagnoses, okay? So P is previous and C is current, okay? So this person here has no experience on radiographs of bone loss and has no significant pocketing. This person here has severe bone loss both on probing, okay, so this is a probing depth that's more than 7 millimeters and greater than 4 millimeters of bone loss on radiographs, okay? So, and you can see that you move on the continuum. The y-axis here will change, and this is the probability in the first graph. This is the probability of reporting oral pain, okay? And here we can see the graph, and we can see two things straight away. The worse the disease is, the higher the probability of reporting oral pain, okay? And this is after we adjust for a whole host of confounders. And the other thing that we can see really strikingly is that historic disease has roughly the same probability of reporting pain as treated, as a person who's never experienced the disease. And as a person who treats periodontitis sort of day in, day out, this is really reassuring to see that this is one of the ways that I don't really tell my patients that we could help them is by improving their or reducing the chances of experiencing oral pain by treating the periodontal disease. And we see a similar trend when we look at the probability of reporting a restricted diet. But we interestingly don't see this trend when we look at the probability of being unhappy with their appearance. And there may be a few reasons why this is. One of this is that we know that the treatment of periodontitis comes at a risk, and it comes at a risk of recession, which has a aesthetic component to it. Okay? So it may be that we're treating the disease, we're improving their odds of getting pain, we're improving their eating abilities, but we're not really helping their appearance that much. And our patients need to be aware of this. The other thing that this may signal is that appearance and periodontal disease are linked in such a way that, so say for example, if you have crowding, you're more likely to have periodontal disease. If you treat the periodontal disease, that doesn't treat the crowding. Okay? So your unhappiness with appearance then stays the same. What this slide highlights to me as a clinician is the importance of not letting someone migrate from healthy to periodontitis or from periodontitis to severe periodontitis, because once they migrate into that category, treating periodontal disease doesn't bring them back down in terms of their appearance. Okay? So just to wrap up really quickly, it's important that we identify risk factors. So it's important that we have a system by which we identify these in our own minds. It's important that we make a note of these in our notes, and it's important that we communicate these to our patients. Because if we have two patients with the same with the same periodontal disease status, and we treat them both the same, if they have different risk factors, then they won't respond the same. Okay. Formal risk assessments are a good thing, but you don't need to have a bespoke system for this, and there are risks involved in missing or misdiagnosing periodontitis that we need to be aware of. And finally, I'd like to invite you to Europerio in Amsterdam. For those of you who can make it, it's the premier perio conference, and thank you all for listening.